ECG in AVNRT. This ECG shows a narrow QRS tachycardia at a rate of around 180 per minute. No P waves are seen to precede the QRS complexes. Then it has to be taken as supraventricular tachycardia. Close scrutiny of the tracing shows probable negative P waves after the QRS complex in lead 2, red arrow. They are called pseudo S waves produced by retrograde P waves. This pattern is seen in atrioventricular nodal reentrant tachycardia or AVNRT. Here the RP is shorter than PR, from retrograde P to next R wave, qualifying for the short RP tachycardia of the slow-fast variety of AVNRT. In the slow-fast variety, an atrial ectopic beat is conducted down the slow pathway as it finds the fast pathway refractory after the previous sinus beat. It may be noted that the slow pathway recovers fast while fast pathway recovers next. This feature is seen in those with dual AV nodal physiology. The sudden increase in PR interval after an atrial ectopic beat or an atrial extra stimulus during an electrophysiology study is known as PR jump. PR jump has to be more than 50 milliseconds to be significant. This tachycardia can be called as short RP tachycardia as RP is shorter than PR. The R waves in V1, green arrow, are a bit too tall to be called as the corresponding pseudo R, but the R waves in AVR are of the size usually seen with pseudo R, black arrow. The taller R wave in V1 could be because there is an element of incomplete right bundle branch block due to the fast rate, phasic aberrant conduction. Corresponding to it, there is prominent S wave in lead 1. Adenosine is used to terminate atrioventricular node dependent arrhythmias like AV nodal reentrant tachycardia and atrioventricular reentrant tachycardia. It is also useful in the treatment of other forms of tachycardias sometimes. Use of adenosine in tachycardias could be for diagnosis of the mechanism as well. Adenosine can induce a PR jump on surface ECG in those with AVNRT, which can be used to differentiate AVNRT from AVRT with concealed accessory pathway. In those with concealed accessory pathway, pre-excitation will not be manifest in ECG as there is no anterograde conduction in that pathway in sinus rhythm. It takes part in the retrograde limb of re-entry in AVRT. Sometimes pre-excitation is not evident in the ECG because of relative competing conduction velocities between AV nodal pathway and accessory pathway. Similarly, it may not be manifest because the accessory pathway is far away from the sinus node as in left lateral pathway. When adenosine prolongs the AV nodal conduction through the slower accessory pathway becomes manifest as pre-excitation. Adenosine usually has no effect on accessory pathways except for atriovesicular pathways and permanent junctional reciprocating tachycardia. AVNRT depends on dual AV nodal pathways, the slow pathway and the fast pathway for the reentrant circuit. Fast pathway conducts faster but has longer refractory period and recovers later. Slow pathway has slower conduction but recovers earlier due to shorter refractory period. An appropriately timed atrial ectopic beat can find the fast pathway refractory and get conducted down the slow pathway. When it reaches the lower common pathway of the AV node, it finds that the fast pathway has recovered and gets conducted back into the atrium in addition to the ventricle, producing an AV nodal echo beat. This is the mechanism of re-entry in AVNRT. When the atrial ectopic beat gets conducted down the slow pathway, there is a sudden increase in PR interval compared to the previous sinus beat. This is known as PR jump. PR jump has to be more than 50 milliseconds to be significant. The monitored tracing shown here illustrates the PR jump for the ectopic beat and an echo beat just after the QRS. Corresponding to the PR jump, during electrophysiology study, an A jump can be demonstrated after an appropriately timed atrial extra stimulus. PR jump can also be induced by adenosine during sinus rhythm. In this case, PR jump is defined as sudden increase in PR interval by 50 milliseconds or more between two consecutive sinus beats. AV nodal echo is defined as a retrograde P wave at the end of the QRS complex as seen in case of atrial ectopic in the previous ECG. Echo beat can also be followed by AVNRT, similar to what occurred after an atrial ectopic beat in the previous case. Thus, adenosine is useful in demonstrating the presence of dual AV nodal physiology from surface ECG, which would indicate that the clinical tachycardia is AVNRT than AVRT. A positive adenosine test identified by a PR jump had a specificity of 94% and positive predictive value of 96% in one study. First set of references. One more reference.